Hello there, I'm Tony Meekum. Today's topic is diseases of the paranasal sinuses, and we're going to cover it across two videos. This first one takes us through normal sinus and the mucosal inflammatory conditions. So get your study guide out, have your chart handy. So we'll work through the sinus conditions across these videos in roughly the order you're going to encounter them, from the trivial incidental findings to the ones that demand urgent referral. This first video is going to cover the normal sinus, mucosal thickenings, mucositis, and retention pseudocysts. The odontogenic lesions that press on the sinus, polyps, and sinusitis. The second video is going to cover the masses, fungal disease, antral, osteoma, mucocele, papilloma, and squamous cell carcinoma, along with the rule for when to refer. Osteoma and squamous cell carcinoma you've already met, so those will be callbacks. And keep one principle in mind as we go through this. In health, the sinus is filled with air, and air reads black on a radiograph, especially in a CBCT. Every condition is a departure from that black, and your task is to name the departure precisely, because the name determines what you do next. Ignore it, treat it, refer it. And one rule, which we'll build toward in the second video, overrides all the naming. An opacified sinus with destroyed bony borders is a malignancy until proven otherwise, so keep that in mind. This is just for a brief foundation, so you're familiar with these paranasal sinuses, where they are. They are air-filled cavities in the face and skull. In health, they're lined by nothing more than a very thin layer of mucosa, so thin that you shouldn't be able to see it on a CBCT. They lighten the skull while preserving its strength. They humidify inspired air, and they're thought to contribute to our defense against infection. Because they're air-filled, they're radiolucent, and that dark background is what lets us appreciate the subtle opacities that we're going to talk about today. And so the sinus develops as invaginations from the nasal cavity with a mucosal lining similar to nasal epithelium and cilia that move secretions toward the ostia and out into the nasal cavity. They develop in pairs and may occasionally grow together. In the maxillary, sphenoid, and ethmoid sinuses, they begin before birth. The frontal sinuses at age 4 to 5. All are small at birth and enlarge throughout life, varying considerably in extent and form. Note variations to recognize: maxillary hypoplasia, bilateral in about 7% and unilateral in under 2%, and the frontal sinus fails to develop in about 4%. So there are a lot of variations to the sinuses, which we'll see examples of. These are several normal variations just to recognize in the sinus: palatal extension, inferior to the nasal cavity, in this coronal CT slice here. In this axial CT slice, we see expansion into the zygomatic process of the maxilla. And then these various periapical radiographs show variation in the size or the extent of the maxillary sinus. Note its position relative to the teeth. Here the sinus is maybe somewhat hypoplastic and way up here. This one's still small but larger than that, and it's encroaching the teeth. This one's probably more average, where it dips down a little bit between the roots of teeth, and then this one really dips down in between the roots of the teeth. And it continues to pneumatize over time, so you're going to see that with older patients. It can really dip down in between the teeth. In this case, at first glance, you see this well-defined radiolucent lesion on the panoramic radiograph, but this is just normal sinus loculation. Like I said, there's variation. Sometimes it pneumatizes into other areas, and it's not necessarily perfectly symmetric. And here we have some more CT slices to compare where the ethmoid air cells are. They're in between the orbits. The maxillary sinuses, in most views of maxillary sinuses, whether they're coronal or axial, it's going to appear triangular. And then you have to get way back here posterior to the ethmoid air cells to see the sphenoid sinus. Here we can see it in this sagittal CT slice. All right, and the clinical features that suggest sinus disease are sensation of pressure, altered voice characteristics, pain on head movement, percussion sensitivity of teeth can be a sinus problem, regional dysesthesia, paresthesia or anesthesia, and swelling and tenderness of the facial structures adjacent to the maxilla. So the imaging options, in ascending order of how much information they give you: periapical might just see a small part of the sinus floor. Panoramic, it gives you quite a decent view of the sinuses, posterior, inferior, anteromedial walls. And then what we're seeing over here is the extraoral, the Waters view, which isn't as popular anymore now that we have 3D imaging so readily available. But that'll show the maxillary, frontal, ethmoidal, and perhaps parts of the sphenoid sinus. Of course, our best view for bony structures is going to be either CBCT or medical CT multi-slice detector CT, which gives an excellent view of bony borders of sinuses and the ostia and can show you patency of all these structures. You can see if there's any mucosal thickening, any fluid in the sinus, really anywhere in the paranasal sinuses. MRI is superior at visualizing the soft tissues, so extent of neoplasm that might be infiltrating it in the sinus. And here we have mucositis. This is the first and most trivial finding. Localized mucositis, thickening of the sinus mucosa. In health, remember that sinus should be under 1 millimeter and not really visible on any of our imaging, radiograph or CBCT. But edema is going to increase its thickness substantially. This is typically inconsequential. I think of it like gingivitis, where everybody has a little bit of it. Maybe it's not perfectly healthy, but in most cases, these are not going to require treatment. So just an incidental finding. Radiographically, it appears as a well-defined, non-corticated radiopaque band, usually paralleling the bony wall of the sinus. So whether the thickness is uniform or isolated around a source of inflammation, the term is still mucositis. Hold on to that because the next entity is often confused with it. And so this is our retention pseudocyst, also called a mucus retention pseudocyst. I just refer to these as antral pseudocysts. This is caused by either blockage of the serum mucus glands in the mucosa or cystic degeneration within the lining. And sometimes it's related to seasonal allergies. As a point of terminology, I want to make firmly, because I don't want to call these mucoceles, even though a lot of dentists do, but a mucocele is an entirely different destructive lesion that we'll reach later, and 2 of those are not interchangeable. The pseudocyst is asymptomatic, more common in men, but you'll see this in men or females. Favors the maxillary sinus over any of the other paranasal sinuses, usually just sitting on the sinus floor. Radiographically, it's just a well-defined, non-corticated, dome-shaped. It appears radiopaque because, why? It's surrounded by air. Remember when we talked about context? When something's surrounded by air, even though it's just fluid dense, if this were in the bone, it might look radiolucent, but it looks opaque in the sinus. Here's a nice egg-shaped one. Notice no effect on the sinus floors whatsoever. Notice no cortical border around it. Those are classic pseudocysts. So definitely be able to recognize these, be able to name them. Don't call them mucoceles. Realize that a large majority of time, these do not require any treatment. And since we mentioned allergies, anyone have seasonal allergies and feel like this once in a while? And here's the differential for a retention pseudocyst. An odontogenic cyst or neoplasm, pay attention to that. The sinus floor is going to be displaced if it's something that arises within the bone. Any odontogenic cyst, including a periapical cyst, if it starts expanding into the sinus, it's actually coming from the bone, and you'll see some degree of a corticated border around it. A malignant neoplasm arising from the sinus is destructive to the bone, not as likely to be nice and clean dome-shaped. So management of pseudocysts is reassuring. These resolve spontaneously. Like I said, a large majority of cases, these don't require any treatment. Maybe just follow up and make sure it doesn't start to cause sinus issues in the future, as it could grow large enough to obstruct sinus drainage, but that's pretty rare. Several CT examples here. You'll notice a recurring theme. Dome-shaped, no corticated border in this sagittal slice. This is also a sagittal slice with a much smaller one, or maybe I just termed that a localized mucosal thickening. Here's an axial slice where it's occupying quite a bit of the maxillary sinus, but notice there's no corticated borders around it, no effect on the sinus borders. This is the same pseudocyst now seen in our MPR view. So we have our axial slice, our sagittal slice, and our coronal slice. And note the field of view almost cut off that lesion. If this were any larger, you might not be able to recognize that it's a pseudocyst. It could look like either fluid or something else going on in the sinus. But now that we can see that it is dome-shaped, it is round, it's non-corticated, you can say with fair certainty that this is just a pseudocyst. All right, and now on to periapical inflammatory lesions. Periodontitis or periapical inflammatory lesion can cause localized mucositis. Any source of inflammation that's relatively close to the sinus membrane can cause that mucositis. Inflammatory exudates may infiltrate into the floor of the sinus and cause a localized mucosal swelling. So look for a homogeneous radiopacity and soft tissue swelling centered on a source of infection, and note the periosteal new bone formation we see in both of these cases. See how there's some sclerotic periosteal bone reaction? That's something that you'll see on any bony border, including the floor of the maxillary sinus. So in this case, we see both. We see a periosteal reaction, see how it's calcified and sclerotic, and then see the sinus border around it with no corticated border. And so that is a mucositis. In this case, it's a response to that localized infection. The mucositis itself doesn't require treatment, but of course you want to monitor this. This has had a root canal, so you want to monitor that over time, just like we would with any periapical lesion. And here's the intrinsic versus extrinsic distinction, meaning did it arise from within the sinus or from within the bone and expand into the sinus? A cyst or neoplasm arising in the bone below the sinus displaces the sinus border upward. These cartoons are showing that. A small lesion here before it started to communicate with the sinus, and then it's growing larger and larger. Here it just shares a corticated border with the sinus floor, and then it starts expanding into the sinus, and it maintains that cortex as it expands into the sinus. And even if it's really large and starting to fill up the entire sinus, you may see an indication of the corticated border of that lesion telling you that this was an interosseous lesion that just expanded into the sinus rather than a sinus lesion that's starting to expand into the bone or destroy the bone. And memorize this image right here, because this really tells the difference between these two things we just talked about. And so which is the pseudocyst and which is the odontogenic cyst? Well, the one without a corticated border that's really having no effect on the sinus border, that should be your pseudocyst. And then in this case, notice the nice well-defined corticated line around it. That's an odontogenic cyst, probably a periapical cyst from this tooth. And so it's that corticated border that really differentiates the two. And here's that same principle on an axial CT of a radicular cyst. Fairly large one that's expanded into the maxillary sinus, but just like we showed in that cartoon, it maintains that corticated border around it. You can see part of the sinus here filled with fluid or mucosal thickening. There's also some sinus expansion as that outward bowing of the posterior and lateral walls of the sinus are seen. But that corticated border inside the sinus border is what tells you this lesion arose within the alveolar bone and displaced the sinus rather than arising from within the sinus. All right, and this is displaying, again, our MPR view where we have the axial slice. In the sagittal slice, you can really appreciate this odontogenic lesion kind of expanding into the sinus, and there's a small 2 to 3 millimeter communication in the sinus. And this is how odontogenic sinusitis happens. You start to get drainage into the sinus that fills with fluid, and that could lead to a sinus infection. In this case, all I see is some localized mucosal thickening, probably some related mucositis. But then here's a case where it went into full-bore sinusitis. As the inflammation started to leak into the maxillary sinus, it occupies now the entire sinus. And once it starts to obstruct the sinus drainage, as we see here, then that leads to sinusitis. And so your job as a dentist, whenever you see sinus opacification, always consider whether the source could be a tooth. So look really carefully at the teeth in that area, because that changes the entire management pathway. Is it just sinusitis? They need to see an ENT, they might need antibiotics, or is there a tooth problem? And here are some cases of dentigerous cyst associated with the sinus floor and displacing the sinus floor. Maybe a little bit difficult to appreciate. Maybe you can zoom in on your PowerPoint and see that there is a corticated border around this, attaching at the CEJ of this impacted tooth. And so that is your typical dentigerous cyst. And this shows the same thing in a lateral oblique view and in a Waters view. And now we have our 3D image. This looks like a medical CT, but now you can really appreciate the corticated border of that lesion in the coronal slice here, and you can see it in the axial slice as well. You can definitely tell this is more fluid filled, or there's something in there as opposed to the normal sinus, which has air in it. And so those are examples of odontogenic lesions impacting the maxillary sinus. Now let's talk a little bit about polyps, which are thickened and chronically inflamed mucosa that's developed into usually irregular folds, more common in the ethmoid, then maxillary, and then the sphenoid sinuses. They may eventually displace or even destroy bone, and in the ethmoid they can invade through the thin lamina propria into the orbit. So very impactful on a patient, producing ipsilateral proptosis. Because they may mimic a benign or malignant neoplasm, this is the rule to apply. If you see bony destruction, obtain additional imaging and potentially a biopsy. And so that's what we're seeing here. Notice the irregular kind of undulating borders. That's typical of a polyp. And here this one has occupied almost the entire ethmoid air cells and the entire maxillary sinuses, destroyed the medial border of the sinus or the lateral border of the nasal cavity. I don't see evidence of the bony part of the concha, so this one's been really destructive. And it's fairly common to see polyps inside the nasal cavity. Once you start looking through CBCTs, you may notice these irregular mucosal thickening. Now the brightness is just the same as normal mucosa, but these are typically kind of dome-shaped. Polypoid means they're kind of sac-like. Usually they have the stalk of the sac superiorly and they kind of hang down. And that's your typical nasal polyp. So if you see that, you got to report on it. They may have nasal obstruction. They may have nasal symptoms and probably want to at least make a note of it, at least talk to the patient and tell them they might want to get this checked out by their doctor. But these are really common. All right, let's get into our typical sinus disease, sinusitis. This is caused from inflammation. Usually it's bacterial, but sometimes it's virus. That leads to ciliary dysfunction and sometimes blockage of the osteomeatal complex. When it involves all of the paranasal sinuses, we call it pansinusitis. Acute sinusitis, being present for only under 4 weeks, presents with pain, headache. That has more of the acute symptoms, fever. Pain increases on bending forward, sometimes a green discharge if it's bacterial, in which case, again, you should rule out a dental source. Then chronic sinusitis is beyond 12 weeks. That's a failed acute infection that's more asymptomatic, except maybe some acute flares. For the in-between, you might use the term subacute. And here we see a Waters view. What do you notice in the left sinus? It looks completely opacified. So is that fluid in there, or is it mucositis? We don't really know. It looks like probably the drainage is obstructed. But on the right side, you see this meniscus line. And when you see fluid in the sinus, that's a strong indicator of potentially acute sinusitis. And for anyone that's had this, maybe you feel like this. Maybe you identify with this picture. Sinus has got me. And so the imaging, I kind of started talking about this on the last slide, but this is heavily tested. So hold these two patterns clearly. As the airspace is lost, the sinus grows increasingly radiopaque. Thickening progresses from the floor to the walls to complete opacification. An allergic process tends to be lobulated or polypoid, whereas an infection process tends to be smoother. So here are the two rules you really must distinguish. An air fluid level and bubbles, especially when you see bubbles or stranding, that indicates acute sinusitis, whereas sclerotic, thickened, bony walls indicate chronic sinusitis. It's been there a while. The bone has been able to react and lay down more dense, thicker bone around the sinus. So acute is fluid, chronic is bone. Those are the two big things to remember. And now this is a case worth pausing on. Where's the difference? I'll give you a second to look at that. Which sinus looks normal and which one looks off? Well, the left sinus is opacified. The posterior border has started to erode. It's kind of absent there. That absent border should raise a red flag because this could represent a malignancy. The opacified sinus alone could just be sinusitis. Again, look for those chronic signs for inflammation, for sclerosis of the sinus border. But in this case, we see some destruction here. And so that's concerning. This patient needed a referral for ENT, both for that concern and also the risk of mucocele when you have a completely opacified sinus. And so remember, an opacified sinus is one thing. An opacified sinus with a missing border is something else entirely. And here we have an axial slice of the CT, and you can see it in greater detail. Now we can appreciate that posterior lateral border is kind of sclerotic. So instead of having that nice, thin, well-defined corticated line, that sclerotic border is what's led to it appearing missing here. So this could just be a chronic sinusitis. Either way, I'd still feel more comfortable referring this patient to get evaluated because of the possibility of transforming into something more detrimental. All right, here's several CT examples showing the coronal slices. What do we notice here in this right maxillary sinus? A nice dome-shaped opacity, probably just a pseudocyst. Here's some just mucositis, but there is a little bit of a polypoid shape, so it could be allergy related. Maybe it's starting to obstruct the drainage. I'd have to zoom in and out of the slices to determine if that is obstructed. And then how is this different? Does it look like just mucositis, or does it look like an air fluid level, an air fluid meniscus? Yeah, this looks like a meniscus, which is a sign it potentially leads us toward acute sinusitis. Also of note, there's a concha bullosa right here. You can read about that if you want. This one shows what's likely air fluid levels in both sinuses, and then look at the ethmoid air cells. And now we've got the osteomeatal complex is the drainage from the maxillary sinus into the nasal cavity, and that's completely obstructed, and you got obstruction, opacification of the ethmoid air cells as well. And this is showing us several coronal slices. It looks like in 1 millimeter increments, coming posterior to anterior. And what do you notice inside the sinus? Not just air fluid level, but there's this kind of frothy, bubbly appearance, strong indicator of acute sinusitis. Drainage still looks mostly patent, but still it's worth reporting on, correlate with symptoms, and see because they potentially have some sinusitis going on now. And so that last one was acute because we saw the air fluid level, we saw the bubbles. What is this one? Very thickened sclerotic borders. It's opacified, maybe more mucosal thickening. Debatable whether there's an air fluid border, but those sclerotic thickened borders tell you what? Chronic sinusitis. And so keep that in mind for the difference between acute and chronic sinusitis. And then what about management? Well, it follows 3 goals: control the infection, promote drainage, and relieve the pain. Acute sinusitis is treated with decongestants and antibiotics if it's bacterial, which in most cases it is. Chronic sinusitis often requires endoscopic surgery to establish ventilation and drainage. And so that covers the normal sinus and inflammatory conditions, the mucosal thickening sinusitis that you most often encounter. In the second video, we'll turn to the masses that occupy the sinuses, escalating from the harmless antrolith and osteoma to the destructive mucocele and then carcinoma. We'll finish with a single rule that determines when you do refer. So see you on that next one. Thanks.